today's topic is robotics in knee arthroplasty. So robotics has been there since many years, though it is an evolving subject. So as we consider a total knee replacement or a partial knee replacement, it is basically a mechanical surgery depending upon the zigs. We definitely use quite a good amount of instrumentation in these surgeries. Majorly, it is quite a good mechanical surgery. We have been doing total knee replacement since many decades. Conventionally, even though we have been doing that, there has been certain amount of patients who have been unhappy with the surgery. Records say the patient satisfaction rate for a total knee replacement, dissatisfaction rate rather, is around 20%, even after doing a very good job in a very good experienced surgeon. So what have we been doing for that? We have been evolving ourselves in terms of techniques with AI and everything. We have upgraded ourselves from conventional to starting to use navigation, as well as nowadays coming down to robotics. So that is how I look after the help that we are taking with robotics. We have to work with the AI. So once we are doing that, we can definitely better our skills. That helps us to just give a consistent result while doing a robotic knee arthroplasty. So coming down, the evolution from navigation, from conventional to navigation and then to robotics. So conventional has been there, we have been doing. After that, we have evolved to image-based navigation. Though earlier we used to have a CT scan. Because of the CT scan, technology was limited at that time. There was difficult segmentation. So from CT-based navigation, we have evolved to an imageless navigation, which we are using today. So in an imageless navigation, basically we mark the bones using the navigation, and we are basically using sensors. We mark the bone and then accordingly plan at the time of surgery, and then make the cuts after placing the zig with our handheld saw. From that, we have now come down to robotics. There are two kinds of robotics: imageless robotics, robotics, and then the latest that is there, that is the image-based robotics. That is because the CT now is better and it gives a better segmentation, so we can plan in a way where we can give better results and better pre-operative planning when we are doing a CT-based robotics. So current stage of robotics, so robotics has been there since the 2000s. Basically, fully active systems like Robotic and Casper have been there. They were taken out of the market because of they failed to improve the clinical outcomes. Potential increase of risk of infection was there. Longer operative times, technical failures on terms of the hardware and the software at that time, and intraoperative complications led to cessation of their use. Like they did not have haptic boundaries and all when they were into use. These were fully automatic robots. The robots that are available in India nowadays are Mako, Navio, Rosa, Cubist, and Velis. These are the 5 robots that are available in India. These are the different companies. So the old generation robots, that the Robotic and Casper, then the Mako and the Velis, which are saw-based systems, Cori, which is a handheld burr, Navio rather, I would say now, a zig-based system, that is a Rosa, where the bone cuts are made by the saw, the Rosa just applies the zig, and a fully automatic system, that is the Cubist, which uses a miller with an irrigation for making the cuts. So coming down to the types of robots that are available, number 1 is image-based, number 2 is image-less. So image-based basically needs a CT scan. We require a pre-operative CT scan. Image-less is direct bone point marking. Then there were closed systems and open systems. So Robotic and Casper were the open systems that were earlier, and the newer robotics are closed systems. Closed systems basically means that only a single implant or the same implant can be used. They are basically company based. So Mako uses Stryker, Cubist uses Merrill implants. Similarly, One more classification is depending upon how the bone cuts are made, that is passive, semi-active and active robots. So coming down to imageless systems, they rely on registration of the patient anatomy by the surgeon. The surgeon inputs at the time of surgery all the data points on the bone marks. The bone points are marked either by mapping or by pinpoint technology. This is subject to human error sometimes, but in the hand of an experienced surgeon, it definitely gives a good results. Pros, basically, there is no need of CT, and it is logistically easier to use these kind of robots. In image-based robots, basically it is 3D CT dependent. So we can target the post-operative alignment as pre-operatively planned using a CT. We get a better bony demarcation. So we are able to plan. So we are able to mark the points exactly. The medial, lateral epicondyles, the femoral anatomy and the tibial anatomy are exactly marked as per the bony this thing. That is why we get a better optimal component size and alignment because of the better bony demarcation. Leg length and offset restoration is basically for the hip this thing. Only the cons are cost of CT and radiation, definitely up to a certain extent, but single CT I don't think so there should be much to worry about. Coming down to the other classification, that is passive robotics, semi-active and the active systems. So passive basically is based on either computer assisted or navigation technology. There is lack of cell constraint haptic backgrounds, no demonstration of improvement of the limb alignment and implant survivorship and the clinical outcome by these robots. Semi-active systems are basically the robotic arm performs the bony preparation. Only it is a surgeon guided this thing. The saw or the burr is held by the surgeon in his hand within the confines of the haptic constraint and as per the surgical plan, whatever we have planned pre-operatively in case of image-based and at the time of surgery in case of imageless systems. Coming to active system, the robotic arm performs the femoral and the tibial bony preparations independently. The surgeon basically maintains control via the emergency manual right button. So that is an active system. So comparative study of all these, QVIS, Mako, Rosa, Navio and Velis now. So out of this, the complete automatic system is the QVIS, Mako is a semi-active, Rosa is a passive, Navio is a passive system, Velis is a semi-active system again. How do we do a robotic surgery? So considering in case of a CT based or an image based, it starts prior to surgery. We do a CT scan. The planning is done 1 day or 2 days prior whenever you are CT scan. It is basically on your laptop, you do a virtual planning at the time of surgery, which will later be demonstrated in our workshop. How do we do it? So once the plan is done, we load that plan in the robo during the surgery. On the time of surgery, there is a system diagnosis. So this is where the imageless start, third this thing. So first two steps we do not have to do in the imageless systems. So at the time of surgery, the system diagnosis is done. There is a non-sterile preparation, that is we have to see that the robo is active, functioning well. Then there is a sterile check that is done. Plus, when we start marking, then there are all the markers are placed in the femur tibia. Registration is done at the time of the bony points. We mark the femur, the tibia, 40 points I have to mark on the femur and 40 points on the tibia. We again make a 3D image of the implant. Then comes to the final and the main stage, that is the gap check and the cutting. So gap check I feel is most important in terms of the surgical procedure. Final is the implantation and the implant result. So resection methods, different resection methods. Mako is saw based, Well is saw based, Navio is burr, Rosa is just applies a zig to the bone, and QVIS is a miller with a irrigation. Factors affecting a successful TKR: lower limb alignment, soft tissue balance, joint line maintenance, and tibial component femoral sizing. So the current advances in orthopedics, in robotics, in knee arthroplasty result in improved accuracy of implant positioning, limb line alignment, implant sizing, reduce soft tissue damage. The conventional method, ligament balancing is important, is essential and difficult to assess and manage. Even experienced surgeons traditionally obtain the soft tissue balance using their subjective feeling rather than the scientific perspective. So this is what a gap balancing tells me. So I can pinpoint it, I can tell how much my gap are balanced pre and post, and whether they are balanced equally on flexion extension. Lesser soft tissue dissection. What are the evidences? There are quite a few papers saying that the technology is effective and cost effective. The robotic assisted are better in terms of short term as well as long term results. They are still assessing the long term results. So a few papers over robotic versus navigation versus conventional. In terms of radiological outcome, robotic TKA shows accurate positioning of the femoral component. This is my paper where we have found out that the preoperative 3D CT accuracy is 100% in femoral component sizing and 97% in tibial sizing, and significant improvement in the varus preoperative from 7.3 to 1.24. The learning curve is around 20 to 25% approximately for a robotic knee replacement. How precise is the determination of rotational alignment in the femoral prosthesis? This is the most important. The outlier in individual techniques is 56% for the TEA, 60% for the PC, 72% for the PCL, 60% for the wide side line, 20% for the gap. When using a conventional technique, hence CT-based techniques are superior. What are the benefits of robotic arthroplasty over conventional? So despite higher cost, robotic assisted TKA offers better short-term clinical outcomes when compared with conventional manual technique, but long-term results require to be assessed further for the implant survivorship and clinical outcomes. Limitations, definitely learning curve. We have to learn, but we are doing conventional. Conventional knowledge is as important, the most important in terms of we have to know how to do a conventional TKR before learning how to do a robotics TKR. Learning curve further adds to this thing. Cost effectiveness depends upon the institute. I feel closed system is one of the things that is a limitation now because we are going towards then we can only use a single implant. Further, if we have an open system, definitely other implants can be used. So thank you.